So this session is looking at one of the great unknowns in spine surgery, certainly something that causes great difficulties for many of us as to what to do. So the organising committee have titled this The Myths and Truths of Degenerative Spondylolisthesis, and invited 3 experts to give us their views and their opinions on what they do, what they think, so we can hopefully come away with some take-home messages. So first of all, we're going to hear from Dominique Rosenflue, who is a professor in Lausanne. He is the next president of Eurospine, but probably know more to us from his time in Oxford before he went there. Sitting beside him, we have already heard from Frank Kleinstock, who is, he's told us all about European Spine Study Group this morning, based in Zurich. Thank you for your great talk this morning. And then beside me, we have Irfan Siddiq from Manchester, who is specialised very much in degenerative surgery, and we're looking forward very much to hear what you're going to hear to us as well. So we're going to kick off with Dominic. If you give us your talk on your views on the myths and truths of degenerative spondylolisthesis. We'll have the 3 talks, and then we'll have a period of questions then before lunch.
Yeah, thank you very much for the kind introduction, and especially thank you very much for the invitation to the organisers, Adrian, Niall. It's after moving back to Switzerland last year, it's certainly very nice to come back here. So, spondylolisthesis. Now, before 2016, the world in terms of spondylolisthesis treatment was probably a bit more simple than it is these days, because most treatment recommendations were really based on the study by Herkowitz in 1991, which was a randomized trial, and we're going to discuss it a bit later again, that clearly showed to them that fusion decompression was superior to decompression alone, and subsequently most surgeons considered fusion in patients with degenerative spondylolisthesis. However, in April 2016, in the same issue of the New England Journal of Medicine, 2 randomized trials came out. The first one was which was the better one with more patients, by Peter First from Uppsala in Sweden. It was a Swedish spine study that looked at fusion versus decompression alone, so decompression of fusion versus decompression alone in patients with spinal stenosis, which included, so they stratified for patients that had degenerative spondylolisthesis and patients that did not. And in each of these strata, they did not find any difference between fusion and decompression alone in terms of the primary outcome, which was an improvement in the Oswestry Disability Index. The second study that was published in that same issue of the New England Journal of Medicine was a study by Gogawala, which was a trial in the US, and instead of 240 odd patients, they only had about 60, 70 patients in their study. And it was a study that was criticized quite a bit. They found that there was actually a superior outcome of fusion versus decompression alone in these patients, but they only saw that difference in the SF36, which is, as we all know, a non-disease specific health-related quality of life outcome. And the Oswestry Disability Index, which was only their secondary outcome, did not show any difference. And since they did not publish their trial protocol beforehand, it was quite criticized, in that basically the result, it seemed as if they chose whatever score showed a difference then as the primary outcome. They also reported a very high revision rate, so up to 34% in the study by Gogawala if you only do a decompression, and 17% in patients that had an additional fusion. 34% is quite a high revision rate for decompression alone. If we when we looked at hospital episode statistics for the NHS in England in about 2016-17, only about 10% revision decompressions were carried out in the NHS of England. So 34%, even under trial conditions, seems a very high number. In the Swedish study on the left, the revision rate was exactly the same. So no matter whether the patients had a fusion or not, they had a 20% revision rate. So fusion actually worked in preventing same level recurrence. But patients then required revision surgery for adjacent segment disease, whereas the patients that had a decompression only, they had revision surgery for same level recurrence. All of these studies, both of these studies, didn't really record whether the patient had a mobile spondylolisthesis, or this so-called concept of instability, which is really an ill-defined term in the literature. That wasn't looked at all. They basically lumped the patients together with degenerative spondylolisthesis or spinal stenosis, and then looked at the outcome. 2 years ago, a Norwegian study, the Nordsten, the degenerative spondylolisthesis trial, was published, also in the New England Journal of Medicine. They didn't try to do a superiority trial. Their design was a non-inferiority trial of decompression versus fusion to see whether decompression was not inferior versus decompression and fusion. In contrast to the other studies, they recorded whether they had a mobile spondylolisthesis or not, but they didn't stratify for it. So they had 20% in each group, supposing or suggesting that the effect of mobile spondylolisthesis would cancel each other out. The non-inferiority margin here was a 15% more patients reaching minimally clinically important difference, and not the actual difference in the change score. And they found that decompression alone was non-inferior to decompression and fusion. So the evidence at this point seems pretty clear that the majority of cases, the majority of patients with a degenerative spondylolisthesis probably shouldn't be fused, as a decompression alone provides an equal outcome, except, for example, there is a foraminal stenosis. Foraminal stenosis, foraminal nerve compression was specifically excluded, for example, in the Norwegian study. If we have more than one level disease, the trials didn't include that. If we have a 2-level spondylolisthesis, for example, if for revision surgery, not necessarily applicable. The effect of a dynamic mobile spondylolisthesis is clearly not adequately studied in these trials. If we have an asymmetric collapse, a coronal deformity, or even sagittal malalignment, that's also not considered. So many surgical factors that we would consider in normal decision making, because when we look at an X-ray or indicate the surgical procedure, we don't just eyeball the X-ray and then decide, well, I'm probably going to do this. There may be some other factors, patient-specific factors, radiologic factors that will prompt us to then decide whether we should do a fusion or not a fusion, and if we do a fusion, what type of fusion, because there is also quite a big choice out there. So fusion angles, for example, spinopelvic alignment, hypermobility in the segment, foraminal nerve compression, the facet joint orientation, or whether we simply can technically achieve an adequate decompression without a fusion is not necessarily considered in all these studies where all the patients are just lumped together. So, and that seems a bit that we're almost going full circle now, going back to the study by Herkowitz in 1991. Why did they do this study? Well, they did the study because they saw lots of failures with decompression alone. And we're asking themselves, should we fuse them? Because they clearly didn't have the same motivation of doing a fusion as we may do now, because the study was done in 1991. They were all non-instrumented fusions. TLIF didn't exist at that point. They compared, it's only 50 patients. The study wasn't done very well in terms of outcome, but or in terms of methodology, but they found a superiority of a non-instrumented fusion compared to decompression alone. And those were, however, decompressive laminectomies, which probably the majority of people don't do anymore, and probably are not as destructive on spinal stability. So either we're much better at decompressing these days, or we're simply just missing something. So the most important research question really that we have in spinal surgery, or probably all of orthopedics, is the indication, which patient really should have which type of procedure. So going away from the lumping on the left side, where we basically just lump all patients together, at the end of the day, we should be able to have some evidence for a stratified decision-making process, which we automatically really already do in our surgical decision-making. One of these factors, we've talked about it already, is mobile spondylolisthesis. Here shown on a supine MRI to a standing X-ray, an increase of slip by 3 millimeters. In some cases, we even have a kyphotic collapse of the motion segment. So should we fuse these patients or not? Do we have less revision surgeries if we do, or maybe even a better outcome? We don't know. We know that the extent of fusion, of the extent of the slip, does not necessarily matter if it is a fixed spondylolisthesis. And First, in the study by First, they looked at that in a post hoc analysis. They compared patients that had a slip greater than 7.4 millimeters and compared fusion and versus decompression alone in this subgroup of patients, and also didn't find a difference. But whether mobility here plays a role, we don't know yet. Why did we choose here a supine MRI or a supine X-ray? That's because the supine radiograph in this study here really demonstrated more reduction in anterior listhesis than the extension radiograph, which always depends a bit on how much pain the patient has, whether they flex and extend adequately or not, because usually extension is a pain-provoking maneuver, especially in a patient with back pain with a degenerative spondylolisthesis. So the supine MRI is probably better, or a supine radiograph is probably better in revealing the hypermobility in these patients. And it's been shown in this MRI study that up to 30% of patients have a translation of up to 4 millimeters, or 4 millimeters than greater. So it's not actually infrequent. Another factor that we identified, which not necessarily has an effect on clinical outcome, but on the rate of revision surgery, which is a factor that we can influence surgically in the way we do our surgeries, is malalignment, and which has been shown to increase the shear forces in the adjacent segment as a mechanism of then accelerating adjacent segment disease. So the patients have up to 10 times higher risk if they have spenopelvic malalignment and are fused in situ with spenopelvic malalignment, as opposed to patients that are properly aligned. Other studies have confirmed this too and found even a relationship between the amount of spenopelvic malalignment and the rate of revision surgery. However, up to recently, we had no indication and no study that really showed whether there is any clinical benefit in restoring alignment in our surgeries. That was a study published in 2017, a systematic review, however, only included 3 or 4 papers, and they found no difference in VAS and ODI where in so-called balanced or unbalanced group. That means patients that had spenopelvic malalignment versus patients that did not. Last year, however, last fall, a study came out from the US, which is a study with over 600 patients, multi-center. It is still a retrospective analysis, but of an observational and prospectively collected cohort study. They propensity score match patients. The primary outcome here were PROMIS, not the ODI, PROMIS, which are quite in vogue, especially in the US, with outcomes after 12 months. I don't really fully understand the data yet, and it has to be taken with a grain of salt. But they found that patients with a mismatch of PI minus LL of more than 10 degrees benefited from a fusion procedure. Whereas, interestingly, if the patients were aligned, they did worse if they had a fusion as opposed to decompression alone. What was also puzzling is that patients that had fusion in the aligned state had much higher revision rates as opposed to patients that were malaligned, suggesting really they must have restored the alignment in these surgeries, which I couldn't really work out from the data presented in the paper. But in conclusion, it seems that probably there is a role for this stratification criterion. Whether it improves then our outcomes in the long term, we don't know that yet. So we can identify specific indications, such as spenopelvic malalignment, mobile spondylolisthesis in patients with 1 or 2 level disease, and essentially design a trial around that to find out whether that improves the fusion rates and whether there is a specific role for fusion in addition to decompression in these patients. So to this end, we carried out a feasibility trial, or tried to carry out a feasibility trial, which was funded by NIHR when I was still in Oxford, and we recruited patients to specifically look at these criterion from 2019 to 2020, until March 2020. We were quite slow in recruitment initially, but then the study was, of course, stopped when COVID came. So we didn't have anything useful out of the feasibility trial except for the screening data. And the screening data indicated that patients that presented to secondary care with with leg pain suggesting of spinal stenosis and had confirmed spinal stenosis in the MRI. In 30% they had a mismatch of PI minus LL, and in the 26% they had a mobile spondylolisthesis as defined by our inclusion criteria. Currently, we're in the process of getting funding now in Switzerland for an open-label, multi-center randomized control trial to demonstrate superiority of decompression and instrument diffusion decompression alone for these specific indications. So not lumping everything together, but looking at these specific indications with the primary endpoint of the change in the Oswestry Disability Index after 2 years. The question, however, when designing this trial was really, how do we define success? Because the minimally clinically important difference for the Oswestry Disability Index, what is most commonly used, is about 10%, 12 to 15% if it's a really stringent study that wants to show a larger effect. 20% has been called a substantial clinical benefit. Well, the minimally clinically important difference is determined using 7 specific methods, for example, anchoring methods that determine the change scores of either responders to non-responders or, for example, treatment to baseline. Now, if we apply that same criterion to a study that wants to study the effect of fusion, that would mean that the addition of fusion will have the same effect in terms of outcome than no treatment compared to decompression. There is no way fusion as an add-on procedure is going to have the same clinical additional benefit than baseline to a decompression procedure alone, because we know very well that the outcome is really governed by the way we decompress much more than the actual fusion procedure. So in this trial, what we will have to look at is the minimally detectable change, which essentially is the measurement error, so anything above the measurement error. This is, by the way, well known in drug trials, for example. You wouldn't expect that drug B, which is supposed to be better than drug A, would have an additional effect that is equal to drug A versus placebo. That's just not possible. But this is how we have looked at fusion in all these studies. So next month, or probably early June, we know whether the study is funded. So in conclusion, the current evidence clearly suggests that there are limited indications for fusion in degenerative spondylolisthesis. It may serve as an auxiliary procedure, for example, in foraminal stenosis, or where we need it, where it helps to achieve our goals of decompression. We may have specific mechanical indications, such as malalignment or a mobile spondylolisthesis, which are not currently addressed in the available studies, and they may have the potential to reduce revision rates and potentially improve our clinical outcomes. In our current practice, it is quite clear that the majority of patients, particularly elderly patients, will benefit from a decompression alone and don't need a fusion. But all patients with 1 or 2 level stenosis need to have a standing X-ray before surgery for evaluation and planning, and we consider fusion, including other patient-specific factors, if they have a PI minus L mismatch of more than 10 degrees, a dynamic mobile spondylolisthesis, a foraminal stenosis, more than 1 level disease or more than 1 level spondylolisthesis, if they need revision surgery, or if they have an asymmetric collapse with a coronal deformity. Thank you.
Dominic, thank you very much indeed. We'll now ask Irfan for his views on the same topic.
Thank you very much, Dominique, and thank you very much, Niall. So we're going to take a leap of faith, and we're going to talk about fusion. Here we go. So we're assuming that fusion is what we want to do, moving on from what Dominique has been talking about. The question then is, do we want to correct the deformity or not? Dominique's already touched on some of this. This talk's going to talk about some of the principles and the concepts behind what Dominique said, and just build on those. So I think before we talk about what deformity, whether we should correct the deformity, we should talk about what the deformity is, and then should we correct it? What's the evidence base? And Dominique's already touched on this. And then how should we correct it? So let's go back to degenerative spondylolisthesis. Let's talk about the local effects of it, the regional and the global effects of it. Locally, we all know about the segmental changes that happen. So locally, I'm talking about L4-5. Generally speaking, degenerative spondylolisthesis most often affects L4-5. The sagittal crane translation and angulation, loss of lordosis and kyphosis. We all know this. The regional effects are a bit more interesting. So you've got changes in the spinal pelvic alignment, and you've got changes in the upper lumbar spine, and we'll come back to that. The global effects, changes in the SVA, changes in overall alignment of the spine, are much rarer in degenerative spondylolisthesis, certainly single-level degenerative spondylolisthesis, so we can perhaps overlook those. So when we're looking through the parameters that we want to define our deformity, the key things that we're looking for is a parameter that's etiologically relevant, that perhaps gives us an idea of the morphological state of the spine before the pathology happened, changes with the pathology, the degenerative spondylolisthesis, that corrects as we correct that particular deformity, and hopefully leads to a better outcome. I would suggest that etiologically, one of the key factors is the pelvic incidence, and this has already been dwelled upon by Dominique. This was a key paper, seminal paper by Barry et al., and there's a lot of work by Rusoli. What they found is, as compared to the asymptomatic population, the degenerative spondylolisthesis have a significantly higher pelvic incidence. Now, if we just go back a little bit, what is pelvic incidence? I think it's important that we recap this. Many of you deformity surgeons out there will love the topic. But just to recap, it's a morphological representation of the pelvis. So it gives you an idea of the shape of the pelvis with respect to the superior part of the sacrum in relation to the acetabulate. It's fairly constant throughout life. There are very mild changes, but it doesn't change with pathology. Rusoli's key work on this really has defined how we look at pelvic incidence and how it influences spinal alignment. We all know everyone walks around with different lumbar lordoses, different pelvic alignments, and really pelvic incidence is the key to the overall alignment of the spine and predicts it. So for example, a patient with a pelvic incidence of 35 degrees at the left side will have a very short lumbar lordosis and a lower magnitude of lumbar lordosis to someone who has a high pelvic incidence on the right side, a type 4 alignment as defined by Rusoli, which will be a long lumbar lordosis with a greater magnitude of lumbar lordosis. It's very important to recognize that it's not only the magnitude of the lumbar lordosis that's key, and we'll talk about this when we talk about pelvic incidence and lumbar lordosis mismatch. Rusoli really defines the length of the lumbar lordosis as being just as important. Two key points really to take from that. What we find in our degenerative spondylolisthesis population, that 85% of our degenerative spondylolisthesis patients fall in the higher pelvic incidence. In other words, they have a pelvic incidence mean of around 60 degrees. So they're all in the type 3 and the type 4 spines as defined by Rusoli. So they all have a relatively long lumbar lordosis, which can even stretch into the thoracolumbar junction in the type 4s, and the magnitude of the lumbar lordosis is significantly greater. If we go back to degenerative spondylolisthesis, so what's the effect of degenerative spondylolisthesis? Well, initially there's the forward translation of the cranial vertebra. There's then, in some cases, extension of the cranial vertebra, which causes more neural compression, but in most cases, kyphosis or loss of lordosis of that cranial vertebra. This paper, again by Barry et al., shows that a predisposing morphotype of spine, which is a type 3 or a type 4 spine on the left, the first thing that happens as you have a kyphosing event in the lumbar spine is that the pelvis rotates back. So these patients exhibit a retroversion of the sacrum. Important note. Secondly, what secondly happens is that they develop a lumbar lordosis in the upper lumbar spine above the level of the deformity. If we look back at our concept of pelvic incidence, what pelvic incidence is composed of is pelvic tilt and sacral slope. So pelvic tilt refers to the position of the sacrum in space. So the sacrum can be retroverted or it can be anteverted. As you kyphose the spine, your pelvis drops back. So it retroverts. Your hips extend, your pelvis drops back, your sacral slope reduces. And that's what we can see in stage 1. So what of lumbar lordosis? The key thing about lumbar lordosis is that it is intrinsically linked to your sacral slope. So when we measure pelvic incidence, we identify sacral slope. We then can define the lumbar lordosis, the lower arc of the lumbar lordosis. There's two arcs to lumbar lordosis, an upper arc and a lower arc. The lower arc is the one that's related to the sacral slope. The upper arc is related generally to a constant of around 20 degrees. To test this theory, that yes, pelvic alignment is key to the outcome and the evaluation of degenerative spondylolisthesis. What we should be seeing in our patients is that preoperatively, patients should have an increased pelvic tilt, and they should also have upper lumbar lordosis. Post-operatively, once we correct that segmental lordosis, we should see a normalization of the pelvic tilt and a reversal of the upper lumbar lordosis. So what I would suggest, as I did, is to go back and look at our own cases and see what we find. So on the left-hand side, we see an L4-5 spondylolisthesis. On the right, we can see a modest correction of that spondylolisthesis in terms of the translation and also restoration of some degree of lordosis, around 8 to 10 degrees. As we can see on the left, we can see improvement from the preoperative pelvic tilt of around 28 degrees to around 20 degrees on the right. So there's some normalization of that initial sacral retroversion and pelvic retroversion to a more normal level. Accordingly, the sacral slope increases from about 32 degrees to 40 degrees, which is what we want to see because the pelvic incidence of course, is constant. In addition, what we also see in that X-ray is a change in the upper lumbar spine, which is interesting. So when one looks at the overall lumbar lordosis, when we're looking at the outcome of these patients, I think it's key to note that you will have increased lumbar lordosis in the upper lumbar spine preoperatively, which then corrects post-operatively. So some of the papers that you'll see assessing overall lumbar lordosis in terms of outcome may not represent changes perhaps from that segment. There's only one RCT really that's been published on this matter, and that was an RCT involving a reasonable number of patients, 73 patients, looking at the concept of reduction in spondylolisthesis and whether it changes outcome. And what's interesting about the conclusion of that paper is it quite clearly states that the restoration of alignment doesn't change outcome. But let's look in a little bit more detail at that paper. So this paper had two groups of patients. Both groups of patients underwent correction in terms of listhesis. One group underwent correction in terms of listhesis, the other group underwent correction without correction of listhesis. So both groups were equivalent in terms of the correction of a lordosis though. So what's interesting is they corrected one parameter in both groups, but then they didn't correct the other in one of the groups. So what you've got here is evidence that your listhesis, your anterolisthesis, doesn't seem to affect outcome. However, your angular correction, your lordosis, does appear to influence outcome. There's been other retrospective studies. This was a 5-year retrospective study looking at spondylolisthesis, degenerative spondylolisthesis, looking at the slip angle, and essentially they had the same issue, is that they had two groups looking at correction of the myodine grading in one group and non-correction in the other, but both groups underwent angular correction, so it doesn't really give us an idea as to whether that angular correction is affecting outcome. There's a couple of papers that Dominique's referred to in the review article that are worth looking at a little bit more detail, that looked at the role of correction of that segmental lordosis. And there was a suggestion in both those papers that there is improvement in post-operative VAS scores as a result of correction of lordosis, segmental lordosis, over and above the correction of translation and myodine ratings. And this again is another paper looking at, it's a very small randomized trial looking at 18 patients who underwent correction or not of pelvic tilt and whether that influenced outcome. And they would suggest that correction of pelvic tilt does improve your outcome. So we look forward to Dominique's forthcoming paper on spinal alignment in that respect. So is there evidence of improved outcomes based on that with correction of pelvic tilt and restoration of sacral slope? The evidence we've seen is quite limited. So we move on to whether there's any circumstantial evidence that improvement in these parameters can help or improve outcome. There is strong evidence, certainly from the adult spinal deformity work and pioneered by people like Schwab, who have looked at pelvic tilt as a parameter and a predictor of outcome. And a pelvic tilt independently predicts outcome in terms of improvement in ODI. So we know that, but that's only in the context of adult spinal deformity in general, rather than single-level degenerative spondylolithesis, which is what we're interested in. So I think on balance, there is evidence that perhaps improvement in pelvic tilt is correlated with improved outcomes, but it's scarce, and really we need more work in that light. So if we were to assume conceptually that restoration of segmental lordosis is useful, how do we achieve that? And in the literature, there's a plethora of techniques which we've all come across that effectively there's no evidence between them in terms of their efficacy, and really it comes down to surgeon preference and surgeon experience. So just to talk a little bit about what we do in Manchester. we've published on this. We use a single posterior incision. We use a single incision approach, a bilateral Wilsey pedicle screw placement, a smaller midline muscle strip, bilateral T-lift type approach, placement of cages, but only after release of the ALL. Many people inadvertently release the ALL, and we feel that's a key in trying to restore soft tissue balance to that particular segment. It's something that we have reported on and published on, and something that seems to give us good results. These are just some examples of straightforward degenerative spondylolisthesis with fairly modest to moderate corrections of single-level spondylolisthesis, but it's the principle of that ALL release that really allows us to extend this particular technique to other pathologies. This is an example of a segmental correction in the lateral plane with lateral listhesis and also rotation. So here we've used a single level correction with rotational and lateral listhesis correction purely through balancing and release of the ALL. We've then extended it further, and even ankylosing spondylitis we can treat through disc space correction and segmental correction and osteotomy via the disc space rather than traditionally as it's done through the vertebral body. Beyond that, we have adult spinal deformity proper, adult degenerative spinal deformity with significant SVA offset, as you can see in this case, SVA almost a foot in front of the sacrum, multiple areas of lateral and anterolateral listhesis in the spine, almost a concertina spine. So we take the same principles of segmental release and segmental correction and try and restore this patient to a normal sagittal alignment, trying to ensure that we maintain maximal lordosis at the base of the spine, L5-S1, with sequential reduction and normal overall alignment. So in summary, we've talked about the spinal pelvic parameters in single-level degenerative spondylolisthesis. We've talked about their relevance in terms of the assessment of the deformity, their importance in terms of giving us an idea of morphologically where this patient's come from, what we need to try and restore, and given some limited evidence as to whether that restoration leads to better outcomes. Thank you very much.
Thank you very much indeed. So I'll now ask Frank to give us his views on this topic. Thank you very much indeed, Frank.
Wow, ladies and gentlemen, being the good Swiss that I am, I naturally concur completely with my fellow Switzerland companion, Dominic, and now having realized Irfan, who I've never met before, is a brother in the spirit of adult deformity surgery, of course, I fully concur with him as well. So I'm not really sure what I can offer to this table that has already been sent, and so you might bear with me for some rambling thoughts, less founded in science. Okay, so this already you've heard, some of you have heard my talk this morning. I am a deformity surgeon by heart. However, I also do a lot of degenerative work, and in this degenerative work, degenerative spondylolisthesis is a big part. So what makes it a deformity in my mind? Why is that important? We heard some issues about that, and how should we address it? We already heard some of that as well. To me, as a deformity surgeon, and I look at a picture like this, patient comes into my office, I immediately think about deformity, just because that's the way I operate. And if you look at this picture, even though the changes are mild, you can recognize them all. You see already a disc degeneration at L5-S1 that may have led to this problem to begin with. Then you have a translation, you have a loss of lumbar kyphosis in the lower level. You already see some rotational problem between L4 and L5. You already see some lateral listhesis. You see that the apex shifted from this level up to this level. So all of this is going on in my head when I see these patients, and I'm certainly biased towards thinking in a deformity framework when I see these patients. And to me, really, degenerative spondylolisthesis is a form of deformity in the way of a really more segmental deformity, not a long problem, but a segmental problem then oftentimes is the starting point that leads towards a bigger problem down the road, thinking about this degenerative cascade that we see so many times. It starts off with some disc degeneration, maybe it's asymmetric, then you get a slippage above, then maybe that asymmetric disc degeneration turns into a degen scoli, and so on and so forth. So it is a deformity for me in the sagittal plane because you lose more often than not lumbar lordosis. Sometimes it's asymmetric, then becomes coronally, but less so. It becomes a deformity of the foramina, as we heard before, and that is very hard to treat with decompression alone and the facets. So again, we heard about lumbar lordosis mismatch, and being a deformity surgeon, this is something I really like to look at. I want to keep my spine balanced, and I want to know that there is as little mismatch as possible. And what is a lumbar lordosis and what is an ideal lumbar lordosis is a tough question, especially in the elderly population. And there are numerous studies out there who looked at this and trying to predict what is an appropriate lumbar lordosis at a certain age, and really the answer is still open. There is some evidence that PI minus LL is not the rule appropriate for each and every one. However, we still haven't come up with a magic formula that fits them all. So we're still working with that. And there are a number of classification systems trying to better assess the deformity part or the structural problematic part of degenerative spondylolisthesis. One of these is the group by Kepler and Vaccaro and the others. And they try to establish a new classification system, not so new, it's been published in 2015. And they also looked at translation, at intervertebral angle, at disc height, with or without leg pain, and they tried to come up with some types of that entity, and they basically proposed 4 different types, the most benign type being just a disc collapse without a kyphosis, then 2 types with various degrees of slip, and then the type D is probably the one that we are most concerned about, is when it becomes a segmental kyphosis. And why is that important? Because segmental kyphosis is a deformity in the making. And it is also important because we come across these patients far more often than we come across these huge, big adult deformity cases that I showed you this morning. So this is a common problem. And more common than not, it is at L4-5. So I'd say 70 to 80% of all cases of degen spondylolisthesis occur at L4-5 more than L5S1. Together, they're probably over 90% of all cases. They're more often in women, they're more prevalent above the age of 60, but being at L4-5 and L5S1 puts them at a place where you have the biggest driver for your lumbar deformity, because, as you have heard before, lumbar lordosis is also somewhat proportionate, and the biggest proportion of lumbar lordosis is exactly at L4-5 and L5S1, basically giving you 2/3 of your overall lumbar lordosis. So if you do have a problem in that specific area, it can very quickly lead to more or other problems regarding deformity. And as we all heard before, deformity is a driver and a problem that leads to poor outcome, poor health quality related scores, and operated and non-operated. So PI minus LL, the SVA as overall alignment, the pelvic tilt, we heard it before, are all clear indicators for poorer outcome and poorer function. And another issue that we see with this spondylolisthesis, degenerative spondylolisthesis, is the issue of instability. And that is a very tough subject to actually clarify and characterize. Everybody speaks about instability, but if you ask them exactly what they mean, how they define instability, you get some very different answers. And some say it's a facet joint effusion, some say it's more than 2 or 3 millimeters of slip angle, or more lumbar kyphosis lordosis. in the flexion extension. So there's a lot of different concepts describing instability. Certainly, if you see an X-ray like this and you see a clear difference between flexion and extension views, increasing the slip angle, a fair amount of mobility still in that segment, it tends to drive you towards a perception that this may be an unstable segment. And the more unstable a segment is, the more stress it has on the disc and on the facet joints, which then deform, they propagate a spinal stenosis, and all leads up to the same problem. And so, how should we address this? We have heard already a lot of different proposals, and I fully agree. First of all, you need to assess as much as you can, dissect this entity of lumbar degenerative spondylolisthesis into its parts. What about the stenosis? What about the facet arthropathy? What about the disc degeneration? What about the instability? And try to assess all these factors separately in order to find a good answer. And you should check the overall alignment, as we heard before, and I fully agree with that. And the longer I do this as a young fellow and early junior attending, I used to do simple lumbar AP lateral, sometimes functional x-rays. Now with my experience at the ESSG, I tend to have full spine x-rays on all these patients as a primary entry, just because overall alignment, you sometimes are surprised what you find. So we talked about this morning. You want to evaluate the overall aspects of the deformity, of the alignment, and that's why you need full spine x-rays if you can, if you feel like doing it. And you compare it to the MRI, because sometimes you see differences in a standing film and a lying supine MRI that are quite amazing. Why? Again, because global alignment, sagittal imbalance is the leading driver of poor function and pain. Now, this is what I mentioned before. If you look at an X-ray and then look at the same patient's MRI, you sometimes are surprised that this is almost no slip and this is a larger slip angle, and I always ask my patient, why do you think that is? And they hardly come up with the answer. Simply because you're standing, and every time you lie down and you stand up, this is going to happen in your spine. It's like a bad ball bearing that runs out into one direction only and just ruins it over time. So what are the options? We heard all of them again, and I fully agree. Decompression is still absolutely on the table for a number of these patients. We looked at our own series at the Schultes Clinic, specifically in degen spondylolisthesis, fusion versus non-fusion, simply by asking them, what is your biggest problem? And if I have a patient that tells me I have 90% of leg pain, claudication, or radiculopathy, and back pain isn't really my problem, I think that patient is still a good candidate for a simple decompression, and I'll still do it today. But some may say, well, why don't you just fuse it in situ? And this to me is probably the least ideal option, because it doesn't address every problem, and I want to either be able to address the biggest problem, or I want to, if I go for surgery anyway, might as well do as much as I can. So that is not the right question for me. It's rather do a 360 fusion with a T-lift and do the reduction and the alignment, which more often than not happens automatically on the table. So that's not such a big work extra. The problems I see with in situ fusion, depending again on the technique you use, be it single posterior translaminar screws or pedicle screws or even standalone fusion, you do not address the sagittal malalignment. You can see it's a plastic deformation. Sometimes I see of the fusion mass. You see continuous kyphosis, even in fused levels, with poor posterior instrumentation. It puts undue stress, in my mind, on an area that needs anterior column support, however you get it in there, and that is adding to the problem. So what do I solve with in situ fusion? I solve a few things, but not all things. And that's why I think it's an incomplete solution. And this is why I do, if I elect to do surgery on these cases, I elect to do as much as I can. I want to reconstruct that alignment. I want to recreate the lumbar lordosis. I'm not so keen on fully reducing. If I cannot fully reduce it, the slip angle is less important to me. But the reduction and the reduction of the lordosis and the alignment, especially for these other segments. Oftentimes you see already a degenerated disc space here, and you sometimes wonder, well, did this happen because of this? You want to protect, and I tell this to my patients, by doing that, I rather protect these levels than keep fusing it in this way, which makes this one work more and actually less protected. So I elect to do a 360 fusion. If I go for fusion, and I think I can solve all the various aspects of that problem list by doing so. That's what I see as the advantage of this kind of surgery. You can rebalance the spine, you can reduce and reconstitute the lumbar lordosis, and you create a stable fixation. And in conclusion, you heard it all before, try and be as meticulous as you can in order to analyze this problem in its several parts, and try to keep an eye on the deformity aspect of it all and weigh the risks and benefits. To me, this is very little extra work if you are proficient in it, so I think it's worth the time. And with that, I thank you for your attention.
Frank, thank you very much indeed for finishing off a fantastic series of talks. Thank you all, the panel. We've got 5 or 10 minutes left before lunch for some questions. If you have some questions, if you'd like to go to the microphone, that would be fantastic. Thank you.
Thank you very much. Some great talks. I think you've hit the nail on the head. Not all decompressions are the same, are they? And I think Dominique alluded to that. I'd just like to ask the panel, if they were going to do a decompression alone, what method of decompression would they do? Please.
Dominic, do you want to go first?
Well, certainly not a laminectomy. These days, mostly unilateral with crossover over the top for a bilateral decompression. So trying to leave the midline intact and do it microsurgically for decompression.
Same here. So I think laminectomies are obsolete. We also do single-sided approaches over the top decompression, leaving one side completely intact.
Irfan?
Not to sound repetitive, but exactly the same unilateral approach, over the top decompression, preservation of the facet as much as possible.
Agreement, it's fantastic.
Sorry, I don't want to bang the drum, but that's quite a culture shift, isn't it? From, say, like when I started, about 12 years ago. Yeah, even moving away from this spinous process osteotomy from Adelaide, Nottingham, that seems to be filtering out now, doesn't it? So, yeah, it's a massive change over the last decade, isn't it?
Agreed.
Thanks. Excellent talk to everyone. I have 2 questions. One to Mr. Siddique. You talked about your ALL release technique. I was just wondering whether you had any concerns about anterior cage migration because of release of ALL, and if you do, how you prevent that?
Yeah, absolutely. So it's an excellent question. And anterior cage migration is an issue, and there's a number of ways that we employ to avoid it. Everything from the design of the cage is key. Often you'll see, and I was talking earlier to my colleague Rajat Verma, often you'll see serrations on the cage that will actually promote anterior migration when you compress posteriorly. So just from the design of the cage to the placement of the cage, so we place the cage very posterior, almost on the posterior cortical rim of the vertebral body. Really, that's where we're going to compress with our pedicle screws, so we get maximal grip at the posterior end, and also it gives us a little bit more leeway in terms of anterior migration. So there's a few things that we do, but yeah, anterior migration is a concern.
And my second question is, Professor Rothenfleur, you mentioned about the radiological criteria for who you'd consider for fusion. In clinical criteria, how much do you consider mechanical low back pain when you consider someone for a fusion?
Sorry, acoustically didn't really understand the question.
So you mentioned the radiological criteria in your last slide about who you'd consider for a fusion for degenerative spondylolisthesis. What is the clinical criteria, and how much do you consider mechanical low back pain as to be a criteria for someone who needs a fusion?
Do patients with back pain affect you at all?
No, not necessarily. So whether I'd be more inclined to do fusion if the patient has back pain? No, back pain to me is not necessarily criteria, because I don't feel we can really solve the back pain problem with fusion. I mostly consider mechanical factors, or factors that I need in order to achieve the goals of surgery in terms of decompression. What's very important is the deformity aspect. It was very nice to see how much this was stressed now already in this session. About 10 years ago, no one, when we had those results, no one really believed it, and we only did biomechanic studies to actually show that there is a biomechanic disadvantage of having malalignment, because people thought that's crazy, right? Why should the lumbar lordosis all of a sudden matter? There was a paper by De Grob at one point that showed it's not necessary to reduce lumbar lordosis, and now we know that it absolutely matters. That there's a spectrum of normal to deformity, and in our assessment, and also in terms of surgical planning and indication for fusions, we need to know where on that spectrum that patient is, and it depends on those type of factors. And then we need to restore the alignment. I feel that there's very few indications for an in situ fusions, at least in degenerative spondylolisthesis. We know that laminectomy has pretty much, not laminectomy, decompression has pretty much about the same results, and then an in situ fusion, and if there is a deformity aspect, then we cannot do an in situ fusion. In fact, we actually can do harm by doing in situ fusion, because the revision rate increases. And once we've fused, we've opened Pandora's box. There's usually no way of going back.
Thank you.
Is there someone in the darkness over there?
Yeah, hi.
Yeah, thank you.
So what I'm hearing from the panel is that a single level degenerative spondylolisthesis at L4-5 is to be treated as a deformity, essentially a deformity problem, and all of them should have, in your view, all of them should have a whole spine standing X-ray in the erect position. Is that, because that's not generally common practice, but is that what the panel is saying?
Yeah. Since I said that, I probably am severely biased in that respect, so I wouldn't never say that you should start assessing degenerative spondylolisthesis with a full spine X-ray as a standard of care. However, I think, based on my experience, that it really adds value to the information if you are inclined to think that way. And not more often, but more often than you think, you find other problems, and then that may help you in argumentation towards a certain treatment. So, to me, it has been helpful.
Just to add to what Frank has said, I think one aspect is actually having an whole spine X-ray. But what I've found, even looking at my own cases for the purpose of this talk, is the quality of that X-ray that's key, really. Because even a whole spine standing X-ray where the hips are not superimposed, where you've failed to be able to assess spinal pelvic parameters, makes it very difficult to make the appropriate calculations and measurements. And I think one of the things we should be pushing towards is obtaining quality sagittal plane imaging, and where EOS and other kind of modern techniques of imaging come into their own, really. But I think increasingly we're finding ourselves, working with substandard quality of imaging and not being able to assess. I don't know.
I agree.
I mean, certainly it's a problem in Manchester.
I think,
Maybe Switzerland's better off.
I think a good quality lumbar X-ray is already good. I mean, with the screening data for the trial, for the feasibility study, has shown that, if you take an X-ray, you actually measure it, 30% of the patients will have a mismatch between the lumbar lordosis and the pelvic incidence above 10 degrees. That may not necessarily matter as much clinically, but it matters when you plan a fusion, because and the studies are convergent on this, and several studies agree on this. If you do an in situ fusion in these patients, then you have a higher risk for revision surgery for adjacent segment disease. And that's why I think the radiographic evaluation is relevant.
Thank you.
Thank you very much. Alex, I think you're next.
Yes, thank you. Some wonderful talks. Alex Gibson, Stanmore. We heard a lot about fusion and a lot about deformity, but we didn't.
Can you speak into the microphone? We really can't hear you with the.
We didn't hear anything about. We didn't hear anything about the non-fusion implants, and I just wondered what the status of that is according to the panel, because it seems either some surgeons think they're quite useful, others think they're the spawn of the devil, and I just wonder where you fell in that spectrum.
Did you get that?
Saying it, Alex, was basically saying about non-fusion implants, is that what you said?
Yeah, the thing, there's various things, isn't there? There's a lot of interspinous things, coflex spaces, all that sort of stuff, which some people are keen on, and I just wondered where the panel thought that had a role or not.
So, yeah, it's a role for interspinous spacers, basically. Yeah. Yeah.
Well, Dionysus, I would say, hasn't really worked, right? Because Dionysus inflection is about as rigid as an internal fixator, as a titanium rod. And therefore, none of the studies have really shown that there is any decrease in revision surgery for adjacent segment disease. In fact, when I was training in Bern and as a medical student in Bern in the late 90s, then they were putting in a lot of Dionysus. When I came back then as a trainee, they were all taking them out again and putting in regular fusions. With regard to interspinous devices, I have no experience with it. I just know the literature. There are 3 randomized trials which have shown that an interspinous device can result into improvement in leg pain similar to decompression, but they had 25 to 30% revision rates. They needed to take the implants again. And when you then consider a value proposition, in terms of outcomes per cost, it's clearly you get the same outcome with a new expensive implant with a high revision rate, and therefore, I don't know about other centers, but certainly in Oxford we didn't use it, and I will never use it.
We're beginning to run out of time here, so we'll just ask the people who are up at the moment questions, then nobody else.
Tom, the whole idea of PI being a constant, as we know recently, is being proven wrong, because there are changes in PI as well. In fact, the X-rays by Mr. Siddiq showed that the PI pre-op was 20 and post-op was 29, if I remember correctly. So are we missing a point here that the PI actually changes because of sacral degeneration, and should we be looking at spinal deformity measurements in a new light?
So,
short answer.
I think essentially, there's some truth in what you've said. The PI does change with age, but the changes that have been demonstrated are extremely small. They're due to changes in the sacroiliac joint. The X-ray that I showed was pelvic tilt, not the PI. But I think you've got a point, but perhaps not to the level that it would influence, our use of PI.
Yeah,
I agree.
There's only a couple of studies actually looking at that. One from Milan. And to me, the changes are so small, they're probably measurement error. If you look at studies that from Finland, for example, that have looked at how accurately can we actually measure the pelvic incidence and the spinopelvic parameters with basically the pelvic incidence, the definition of the sacral plateau varies the most out of all the spinopelvic parameters. So, whatever is plus minus 5 degrees or even more is essentially measurement error. So I think it is very difficult to determine whether you actually have a true change of a few degrees. And the other question is, does that really matter?
Thank you very much. Last 2 questions then over here.
I'm Leonard Lutchman from Norwich. To the whole panel, the tendency for the patient to stand in a kyphotic or stoop forward position when they're stenotic is a common observation. I like SVA as a global measurement because it's easy to do. But surely SVA as a global measurement will over-represent the deformity because of the patient's stenosis. And we know a good decompression, the patient comes back standing upright. In helping you to decide in that patient whether or not to fuse them, have you found the pelvic incidence to lumbar lordosis mismatch to be a useful index as to whether or not you're going to fuse them or just decompress them? Does it help you resolve the difficulty of the patient's global posture being influenced by their stenosis, if you see what I mean?
I would say there is not one single parameter that, is your defining moment. So it's all pieces of the same puzzle. And yes, I do see these patients that just simply do not want to stand upright because it hurts them. And when you ask them, are you riding a bicycle and can you sit without problems, where they actually exert pressure on their back as well, and they say, I have no problem with that, that then again is an additional information. Another information could be, and we haven't really talked about this in the workup, of using infiltrations, diagnostic infiltrations, stenotic infiltrations in the canal versus facet infiltrations, going more for mechanical pain. That opens up another can of worms, discussion on the usefulness of infiltration. But in my practice, I think all these various aspects together at the end form the decision.
Thank you. Ashley, last question then.
Thank you. Ashley Cole from Sheffield. Can the panel just confirm that for the vast majority of patients with lumbar-spinal stenotic symptoms or radicular leg pain with a degenerative spondylolisthesis, that the evidence would suggest a decompression alone is what is required and not instrumentation?
Yeah, that was the conclusion of my talk, exactly.
I would say partially, because you do have that problem in the slippage in an unstable situation where you can have significant foraminal compression that can have the same symptoms, and then at this point...
If the spondylolisthesis is stable.
Even though, if you have significant foraminal stenosis, sometimes decompression alone can be tough.
I think it's a fantastic question, and I think it's very difficult. I think it's a case by case. I think there's the number of clinical factors, radiological factors, consent factors with the patient, physiological factors of the patient. I think we have to consider all of those, as we do in our clinical practice, before we offer one over the other. But decompression is certainly, up there as the number one or two option.
He asked the majority, not all patients.
Yeah.
So I would agree, the majority, and that's what the evidence indicates, and I've outlined where the evidence is not applicable, but that's not the majority.
Okay, well, thank you very much. It's been a fantastic session. I hope you all enjoyed it. I want to really thank the panel. Thank you very much indeed.